Welcome everybody to the Family Voices of California Brown Bag Lunch Training Series, a training series on health and policy topics affecting children and youth with special health care needs. Our presentations are geared towards families, professionals, parent-to-parent staff, youth, and anyone else interested. Today's topic is Navigating California Children's Services, the Financial Process and Health Insurance Plans with Sue Johnson and Teresa Enns. Before I hand it over to them, I just want to give you a few notes about the technology. Unless you're absolutely sure you have a headset with a microphone that allows you to speak through your computer, to participate and ask questions, you'll either need to call in or type in your questions. You can find the call-in number from your email, or while you're connected, go to the audio menu, select Use Telephone, and it'll give you a dial-in, an access code, and an audio pin. Just please remember, if you're calling on the telephone, enter in that audio pin. If not, you'll get a little chat from me reminding you. And if you have any technical difficulties, if you can't hear the audio, you can call GoToWebinar directly. Write down the number. It's 1-800-263-6317. Again, that's 1-800-263-6317. Or you can send me, Tara Robinson, a chat or a question. So owing to feedback issues, we generally have everyone on mute from our end. There will be opportunities to ask questions, and when you want to ask a question, there's a little hand icon located in the control panel. It's a small column to the left of the menu, little hand with an arrow. If you click on it, we know you want to be unmuted, that you have a comment or a question. But if you have any trouble being heard, you can also type in a question in the box. And lastly, we will definitely send out links to the presentations today to everybody, as well as a video of today's presentation. With that, I'm going to go ahead and turn it over to Sue and Teresa. And welcome, guys. Thank you for being here.
Thank you. This is Terry Enns, and I'm with CCS. We're with CCS Alameda County. We have 3 presentations, so at the end of the first presentation, then we'll take some questions, and then at the end of the second and the third. So I'm going to start with the first slide, CCS, California Children's Services. Every CCS program, there is one in every county. Some are independent counties where they have a lot of staff, such as ours in Alameda County. Others are dependent counties, and they have minimum staff, and the state does the authorizations for them. We're having some technical difficulty in advancing the slide.
Okay, if you guys go to the bottom left of your, there you go, you got it.
Okay. So our mission and vision statements are to provide appropriate specialty medical care to eligible California children in a timely manner. And again, we have to specialize, we have to stress specialty care, because we do not authorize general care, or in general, we do not authorize services of a pediatrician. So it is specialty care under the direction of the state children's medical services. We get directives, regulations, letters called numbered letters, information notices, and all kinds of information on the specifics of what we can authorize, how to do it, and they're very detailed. CCS is a program, not an insurance. A little history is that it started about 80 years ago or over to address the medical and rehab needs of children that were affected by polio. And then over time, diagnoses were added to the program. And the current program now covers many, many multiple types of conditions that require specialty care for physical, medically eligible diagnoses arising from injuries that are chronic or acute problems. And we have to stress physical, because we do not authorize behavioral problems, developmental delay, or autism. And we do not authorize services for the whole child. We only cover the particular CCS eligible condition, so it is by systems. There are 2 components of the program, the administrative and the medical therapy program. The administrative is where we do the authorization for the specialty care or for the facilities. And that is also where the case management takes place. And the other component is the medical therapy program, and Sue will be talking a little bit more about that. Some kids have conditions that are eligible for both components of the CCS program. So a child might have services where we do authorizations for special care, as well as they would be receiving the medical therapy program services. So the administrative program, the eligibility requirements are that the child be from birth to age 21. After they're 21, they are transitioned out to adult care. They have to be medically eligible for the very specific CCS eligible condition. They must be residentially eligible. That means that they reside in the county and they have intent to reside in the county. And this is where we do not look at particular documentation as far as citizenship, because we do take undocumented clients. They can apply. And they must be financially eligible. So primarily they must be low income. And we have social workers here in the CCS program that help the family with the eligibility. The financial eligibility is that they must meet the guidelines of being under $40,000. That is for the family. It does not matter how many children they have in the family. And the $40,000 is not exactly always, because if they have out-of-pocket expenses, we can take that into consideration. There are two state health insurance programs, and these are Medi-Cal and Healthy Families. And if a family has either Medi-Cal or Healthy Families for their child, the child is eligible financially for the CCS program. With full scope Medi-Cal, CCS can issue authorizations with no problem. With Healthy Families, we can also issue the authorizations as long as we verify that they do have healthy families, but the services are pre-authorized. So we must authorize them before the service takes place. If a family has private insurance, we can take that and as a primary billing, and those services are billed first. Those insurances are billed first. The state mandates that CCS case manages for Medi-Cal and for Healthy Families clients. So we do the case management for them. If a family has an HMO, which is a private plan or a commercial plan, such as through the parent's employment benefits, there are CCS requirements prior to authorization, and they are that the requested service is not a benefit of the plan. So oftentimes the type of requested service we might have is a piece of equipment, DME, and it is not a benefit of the plan. And that's when we would authorize services for a child who has an HMO. Or the service, and the service has to be for the CCS condition, and a denial or statement of the benefits is required, and the family must be financially eligible. Some of the program services of CCS are medical authorizations for the specialty care, authorizations to special care centers that are multidisciplinary centers to provide that care. An example would be for diabetes or for cancer treatment. We authorize hospital authorizations, outpatient surgery, any of the follow-up care for that condition, pharmaceuticals and supplies, durable medical equipment, skilled nursing. For example, if a child needs skilled nursing after being in the hospital and had a Broviac line placed, and the family needs instructions on care of that, we would authorize that skilled nursing, again, for the CCS eligible condition. These are some of the special care centers that we authorize. There are others. There's 2 slides of this, so this is not it. And these are multidisciplinary centers, which means there may be 1 or 2 physicians or subclinical specialists, nurse practitioners, clinical nurse specialists, social workers, dietitians, nutritionists. So they all come together to take care of that complicated or complex condition. And another example would be craniofacial center, where there is an oral surgeon, physician, dentist, plastic surgeon, and some of the other components like nurse practitioners, social workers, dietitians perhaps. So there are, these are some of the centers: cardiac, cochlear, communication disorder center for the hearing impaired, craniofacial center, endocrine, where we cover conditions such as diabetes, gastrointestinal center, hematology, high-risk infant follow-up, neonatal intensive care unit, pediatric intensive care unit, pulmonary, rehab, spina bifida, and transplant center. For the most part, these are outpatient services, outpatient centers, except for neonatal intensive care unit, pediatric intensive care unit, and rehab center. On top of a child being individually required to have these eligibility requirements, there are also state CMS requirements. And that is that the doctor that is treating this child for a simple condition be CCS paneled. The state does the paneling, and they are approved, and therefore we can authorize these services. And a simple condition would be perhaps an eye problem, so we authorize the ophthalmologist, or a child with severe seizures, so we would authorize the neurologist. Other conditions require that they be followed up in an approved special care center. And I mentioned the cancer treatment, so we authorize hematology oncology or endocrine for diabetes follow-up in an approved special care center. If they are hospitalized, the state mandates that they be in an approved facility. And these are usually the tertiary facilities. For us here in Alameda County, it would be Children's Hospital, UCSF, and Lucile Salter Packard at Stanford. And this would be for inpatient services. The medical therapy program services in the MTUs provide physical therapy, occupational therapy, and medical therapy clinic for those clients there. And there is no financial requirement for these services that are done through the medical therapy program. So we'll go into that a little bit more. Anyone can refer clients to CCS. You must have the request. You must have a specific request for the CCS services. There is a completed CCS worksheet that is available that has all the demographics, the child's name, address, and what specific service you're looking for, phone numbers, and that sort of thing. Or for facilities, they usually send in a face sheet with all of that information. The medical reports are the eyes and ears for the CCS program. These are very important, and the specific medical report for that specific condition cannot be understated here, because this is essential. You can fax to your local CCS office, and to find out the number for your CCS in your county, you can check the website. And this is the website for CMS, and this is what the website would look like. And there's 3 sections, and it's kind of fun to go through it. Individuals on the left. Contacting a CCS program is the 4th one under the left column, individuals. And it does have all the numbers and everything. The middle one is on providers and provider forms, and the one on the right is the different information about the CCS programs. You have forms and letters. Under there is letters, if you click on that, and then numbered letters gives you very specific information about a specific type of authorization. This is my piece. I can take a few questions now, or we can go into the next set of slides with Sue.
Okay, so if people have questions, they can go ahead and send them in now, or raise your hand if you want to be unmuted. So let's give people just a moment. If not, we'll move forward. All right, I have one hand. Let me see if I can unmute Mina. Mina, are you there?
Yeah, I'm here. Can you hear me?
A little bit. If you can speak up or get closer to the speaker.
Okay.
There
Is
you
it better?
That's better.
This is specific to my case, basically. I'm just trying to understand how it works. I did see how the HMO and the Medi-Cal piece would work with CCS. In our case, we do have HMO, we do have Medi-Cal, and there was a DME equipment which was approved. First it was denied by HMO, and then it was approved by Medi-Cal. And then CCS took over it, and I couldn't understand why they took over it, but then now I see it's a mandate that they are supposed to take over the case management for Medi-Cal also. So CCS took over it, but the CCS rejected it. I could not understand why CCS would reject it when Medi-Cal has approved it. So basically, it's just in a limbo right now. Could you briefly explain if that can happen when the primary HMO has denied and the secondary Medi-Cal has approved? Why would CCS deny it? I mean, can they deny it acting on behalf of Medi-Cal?
Okay, it sounds like, without knowing about the child or the condition, it sounds like the child has an HMO commercial plan as well as full scope Medi-Cal. If that is the case, then the health plan can be limited in what types of services that they are authorizing, approving, or providing. And since they are the primary insurance, that's the one that Medi-Cal will go for first. If they deny a particular service or piece of equipment or whatever it is, then it goes to CCS if the child has a medically eligible condition. And at times, they might be denied by CCS because the child does not have a CCS condition and may need a piece of equipment, and therefore, with our denial, the child can still provide some services directly from Medi-Cal as long as the HMO commercial plan has denied it. Does that make sense?
Yeah, it does. That's exactly what I asked the provider, the vendor, actually. So I told them, okay, if CCS denied it, can we just use the authorization from Medi-Cal to move forward? And they haven't gotten back to me. From what you're saying, it does sound like even if CCS denies it because it's not a condition that they cover, the Medi-Cal authorization can be taken independently and move forward.
Yes, that's what we recommend, is to take CCS denial and take your HMO's denial and attach them to the billing for the service that the child needs. You might want to get some guidance from your local CCS office as well.
Okay. All right. Thank you.
Great. Thank you, guys. Okay, seeing no other questions at this time, why don't you keep going?
Okay. I'm Sue. I'm with the medical therapy program in Alameda County CCS, and I've put my email address on the slide in case you later have some questions you want to forward directly to me as well. I'm going to talk about therapy services through CCS, what they are, who is eligible, how to access them, and how they interface with other health insurance plans. Therapy services are available for children through two separate parts of the CCS program. We will first talk about services available through the medical therapy program. A little bit about history. I know Terry covered some of this, but in 1927, the California State Legislature established the California Crippled Children's Act to ensure that children affected by the polio epidemic had access to rehab services. In 1945, a medical therapy program, or what we call the MTP, was established as an interagency collaboration between the Department of Health Services and Department of Education to take these services out of the hospital and bring them to the community and put them directly at school sites so that they're more accessible to the child. The medical therapy unit, or what we call the MTU, is where these services are delivered. They are located at public school sites. The space and equipment is provided by the school district, and staffing is provided by the local health department, funded by both state and county funds. When the MTP services become part of the child's IEP or individual educational plan, the school may provide the transportation to the MTU through school busing services. Children who are eligible for the CCS medical therapy program are aged birth through age 21, just like the general program, have a condition that is physically handicapping due to a neuromuscular, musculoskeletal, or muscular disease. Children under age 3 who may be considered at risk for developing cerebral palsy but have not yet been diagnosed are considered provisionally eligible through age 3 or until a diagnosis is confirmed or symptoms have resolved. The following diagnoses are examples of potentially eligible conditions for MTP services. Conditions or disorders that are physically handicapping or cause significant physical limitations are generally eligible. Children with cerebral palsy make up 80% of the caseload in the MTP. Those eligible for the medical therapy program have cerebral palsy with symptoms of spasticity, ataxia, apoptosis, or dystonia. These are neuromuscular symptoms that cause involuntary muscle contractions or uncoordinated movements. Diagnoses of developmental delay or hypotonia are generally not eligible. There are no financial eligibility requirements for the medical therapy program. As long as services are received at the MTU, there is no cost to the family. Anyone can refer a child to the medical therapy program. Frequently, these referrals come from the primary care physician or specialist. However, a parent can refer or somebody from the school district can refer as well. However, in order for a case to be open to the medical therapy program, a child must have an MTP-eligible diagnosis. There must be a current medical report that supports the diagnosis, and a prescription for physical or occupational therapy services. At the MTU, an initial intake assessment is completed, an orientation to CCS is provided, and the family is introduced to the family liaison. In Alameda County, the family liaison works for our local family resource center. With the family's consent, the CCS family liaison makes a phone call after the initial intake interview, and the family is introduced to the services provided by this valuable service agency. At the MTU, there is minimally a physical and occupational therapist and a physician who oversees the medical therapy services. Depending on the size of the county or caseload, there may be additional staff such as therapy aides that assist with the delivery of therapy services, and potentially social workers, nutritionists, or nurse case managers that attend the medical therapy conferences. The Medical Therapy Conference Team, or MTC as we call it, is a collaboration of the MTP physician, the parent, and the physical and occupational therapist. Together, specific functional goals are created, and a therapy treatment plan is prescribed to support these goals. Services include physical and occupational therapy directed towards the achievement of specific functional goals, such as learning to walk or use a wheelchair, to be independent in self-care and activities of daily living like bathing, dressing, and toileting. These services may be in the form of direct hands-on therapy that take place weekly at a specific prescribed frequency. A child may also be monitored by a physical or occupational therapist for progress on developmental milestones or status of physical conditions. Physical and occupational therapists are also available for consultation to the parents, caregivers, school teachers, and other agencies who are working with the child. Durable medical equipment and adaptive aids are an important adjunct to a child's ability to help his or herself. MTU therapists provide consultation on equipment needs and are available to make recommendations. Typical equipment on which they may provide advice or training are wheelchairs, walkers, communication devices, splints, and braces. CCS can authorize this equipment for families who financially qualify. This equipment is paid for through county or Medi-Cal funds. Other services available at the MTU are referrals to other health professionals by the MTC team, referrals to other agencies such as the Family Resource Center, regional centers, Department of Rehab, and other community programs. There's also therapists can also attend IEPs to make recommendations for the classroom environment, and they're available for the provision of family trainings. Once children reach ages 14 through 18, the focus at the MTU gradually shifts to that which supports them as young adults, with an emphasis towards self-empowerment and a transition to adult-based providers. The MTC clinic is geared towards transition issues. Referrals are made to community agencies that serve the teen or young adult with disability, and therapy in the MTU may incorporate new age-appropriate functional skills. The Family Resource Center can be a great resource for families with children who are preparing to age out of the CCS system. Services may include specific trainings, support groups or services, and assistance with IEPs and ITPs, which are the individual transition plans for the school district. MTU services can be vendored in lieu of MTU if there is no MTU within 30 miles, if there's a lack of staff or a wait list for services. Vendoring can also be done if a needed modality is not available, or because of a client's age, it's more appropriate that he or she be seen at an alternate approved site. Vendored MTU therapy services will be billed first to the private insurance. CCS will pay the difference if a private insurance does not pay the full amount allowed by Medi-Cal. If there's no other insurance involved, CCS will pay the full amount allowed by Medi-Cal. Requirements for authorization are that the service must be prescribed by the CCS or MTC physician, the PT and OT are CCS paneled, and the facility must have a Medi-Cal provider number or an NPI number. Now, Medi-Cal typically allows only 2 OT visits per month unless it's an approved outpatient rehab center. However, EPSCT is a program that provides additional benefits for children and will authorize medically necessary OT visits prescribed by the CCS physician. This part is usually invisible to the family and is handled by CCS. Therapy services are also available through the general CCS program. The following services, PT, OT, and speech, can be authorized for the treatment of a CCS-eligible condition. Conditions that are typically eligible for therapy through the general program include complex orthopedic fractures, peripheral nerve injuries, cancers, blood disorders, cranial facial conditions, cardiac disorders, and hearing impairment. In order to receive these services, the family must be financially eligible, private insurance must be billed first, the prescription must come from a CCS panel physician, and the therapist must be CCS paneled. I'd like to talk a little bit about speech pathology services. Speech pathology or speech therapy is for the treatment of communication disorders or feeding and swallowing issues and can be authorized by CCS when the pathology is related to the CCS diagnoses. Speech delay in of itself is not a CCS eligible condition. Generally, conditions that make articulation difficult because of poor oral muscular control or oral motor weakness are the types of disorders that are CCS eligible. There's an overlap in the area of feeding and swallowing in that both OTs and speech therapists are trained to work on swallowing. Depending on the community, one or the other discipline may take the lead on this. In cases where the feeding and swallowing disorder is related to a MTP diagnosis, and if there are OTs with advanced practice certification for swallowing in the MTU, then this treatment might be provided at the MTU. Speech therapy services are not an MTP benefit. They are a CCS benefit if related to the CCS diagnosis, and as with other CCS medical services, family must be financially eligible, the private insurance will be billed first, and services must be prescribed by a CCS paneled physician and delivered by a CCS paneled speech therapist. As with the OT, Medi-Cal will only allow 2 visits per month, so if more frequent visits are necessary, these must be provided at a Medi-Cal certified outpatient center, or they would be paid for by through EPSDT or county funds. Again, that part is usually invisible to the client as well. For children under 3 years of age, speech services may be available through Early Start programs, but may be referred to CCS first. If the need for speech therapy is related to the CCS medical condition, then CCS will be the primary source of services. For children over 3 years of age, speech therapy services may be available through the school district, but the child must meet criteria for education-based services. If medically necessary speech therapy services are appropriate for the CCS diagnosis, then CCS can authorize these services, and they may augment the school-based speech therapy services. The CCS relationship with its community partners is very important. The Family Resource Center offers support and resources for families and is staffed with parents who have been there and can help families navigate through the matrix of services available for the child with special health care needs. Your local regional center may also provide services that are not available through CCS. A referral for special education may offer assistance in the classroom, which will help a child access education resources. Coordination with local health plans is an important way to ensure that the best services are being provided for a child. The next part of the presentation will go into more detail about the financial processes. So I'm happy to answer any questions now about therapy referrals or therapy services if you'd like.
Okay, so if anybody has any questions, go ahead and do your raise your hand function. I have one question that came in a little while ago. Susie asked, will CCS pay the copay if the commercial HMO is used as the primary?
And this is for therapy services or for?
You know, she doesn't specify.
Okay, well, for therapy, if it's for in lieu of medical therapy unit services, this will pay for that copay, and because there should not be any fee for the child for medical therapy unit or medical therapy program services.
And for the general administrative program, if a child has a commercial HMO plan or some other insurance and they have copays and they also have full scope Medi-Cal, Medi-Cal will pay for those copays. Any other situation is handled on a case-by-case here in Alameda County. If they have I'll go into the other types of insurances, but if it's not an HMO commercial private plan, then our authorizations will cover that care, and we use the funds, you might say, from the private insurance first. I hope that answers the question.
Great, thank you. Let me see if I can unmute Joan. Joan, are you there?
Yeah.
Hi.
Actually, I just typed the question and sent out. But so we are actually receiving services from CCS, but I haven't heard anything about the Family Resource Center. So I'm just wondering what it is and where can I find more information about it?
Oh, actually, let me jump in on that one. Joan, if you want to contact me afterwards, this is Tara Robinson with Family Voices. I can help connect you with your Family Resource Center.
Okay, great. Thank you.
Thanks. Let's see. We have a question from Janelle. Janelle says, how are therapy services managed in dependent counties without an MTU or a CCS paneled OT or PT?
Well, those requests would go through the regional office. If there's no MTU, usually there's, well, through the regional office, the nearest panel therapist is identified and authorized to provide those services. And if there's a problem with accessing those services, the county health department should be working with the family in terms of explaining where the nearest available approved therapy clinic is. And there, it might be possible to get assistance with transportation, reimbursement for mileage if they have to travel pretty far.
Great, thank you. Let's see. One question from Amy. Amy asks, to verify MTU is free, are there CCS assessment fees for MTU children?
That may vary from county to county, so I would talk to the local office about that.
Okay, and one more, let's see, let me see if I can undo. Monica. Monica, are you there? Can we hear you? Monica? Okay, Monica, if you have a question, go ahead and type it in. And let me try Mina. Mina, you there?
Yeah, I'm there. Can you hear me?
Yes.
Okay. Now this question is based on the MTU, again, based on what I had experienced with my son. He received physical therapy for a couple of years, and then they told me that he's not making any progress, and therefore he cannot be kept in the program, which I found kind of conflicting, because if a child is not making progress, then that means he needs to be taught in a different way or maybe in a different manner. So it does say that he needs more help because he hasn't met his goals and he's not making any progress. But they stated that as a reason to take him out of the program, which I find rather, different. So I was just trying to see, is that a reason to drop somebody out of a program?
Yeah, not knowing this specific situation or the diagnosis of your child, I would say that it's more likely he's on a monitored status. There are certain periods, certain times of the child's developmental status where they're more ready to take advantage of the therapy services, and so direct hands-on would be provided during those times, and then the child's monitored. It might be twice a year, 2 to 4 times a year. Some kids that there isn't very much, maybe doesn't have many needs, even equipment needs, might come in once a year. But as long as the child has an eligible diagnosis, they continue to be in the program through age 21. And it's during those monitored visits that they're reassessed and possibly restarted on active therapy services. There's also the situation where children under 3 qualify under a different set of criteria. And I mentioned that if they appear to be, if a child appears at risk for developing cerebral palsy, they can be an open case with the medical therapy program. But at age 3, if there is not there's not a diagnosis of cerebral palsy, then they're transitioned out of the program. I don't know if that's the situation in your case.
You were correct to that extent. They did say that they will monitor him and he is on a consultation, like we go and visit them and they assess him. But I had asked them, so what are the factors that you're looking for that will say he's ready to get back into the program, into the active status? They didn't have an answer. So I wasn't quite sure if there's no criteria that they're looking for, or if there's no criteria they're able to point out, which will tell them what makes him ready, then how are they going to know when he's ready?
Yeah, and I think that's something to discuss with the supervisor of the unit, and bring your concerns there. But I would definitely, if you're feeling like there's, especially if there's some issues that you feel need to be addressed, then I would take that back, to the clinic physician and to the MTU supervisor.
Okay, great. Thanks, guys. Why don't you guys keep going? I'm going to make sure we stay on time.
Okay, so we're going to talk about the financial insurances, managed care, FE, the whole money thing, and we'll start with Medi-Cal. This is actually, these two slides, this one and the next one, are an overview of the type of financial situations that we see. The first one is Medi-Cal, and the different types of Medi-Cal are full scope Medi-Cal, with no managed care. It's just straight Medi-Cal. Sometimes we see kids with code 60 or 20, which is through SSI. And then we have managed care. It's also full scope Medi-Cal. Then there's share of cost, and these are seen, this one and limited Medi-Cal are seen as CCS only clients because they need to come in for a financial interview. Then there's gateway Medi-Cal, which is a temporary type of insurance. The other, the second category that we have for our clients is healthy families. And if we verify that they do have healthy families, we can authorize them just like full scope Medi-Cal. The other type is the private insurance. We've already touched a little bit on the HMOs, the Health Maintenance Organization, which is a private insurance. It is a commercial plan. It's usually through the child's parents' employment benefits. And these families have usually a specific request that their plan does not pay. For these, we usually do not authorize the physician medical care. Then there's the PPO, which is the preferred provider organization. These are the ones that if a client comes in and they verify that they are under $40,000, we can go ahead and approve the case, and when we do the authorizations, we say on the authorizations to bill the private insurance first. On the EPO, it is handled as either an HMO or a PPO, so oftentimes our social workers have to find out from the particular insurance if they are HMO or PPO. Then another category of private insurance is the POS, which is point of service, where a certain amount is paid at the appointment. And for these types, the EPO, PPO, and the POS, we do have our social workers work with the families to see if they qualify for our program. There's also some some counties may have private insurance plans that are through the managed care plan. And I'm not talking about those plans under Healthy Families or under Medi-Cal. These are private plans that the managed care entity came up with. And they are wonderful because oftentimes they will take kids that are undocumented. For example, here in our county, Kaiser has such a plan. We see them as commercial HMO plans because they cover the whole child. The fourth category that we see here are where a child has no insurance. Oftentimes they're undocumented. And for those cases, we use CCS funds to provide the medical care for these kids. Here is a little guide. Here's where I need my pointer. How do I do the pointer? Oh, here it is. All right, so we start out with full scope, and I've already touched a little bit on these. Full scope or straight Medi-Cal, there is no managed care here. A child comes in, we review for the medical eligibility, and then we find out that they are eligible medically. Then we review and find out they have straight Medi-Cal. We can authorize straight, there's no detours, and there is no financial eligibility required, usually no application or a program services agreement. Although we do send one, but in order to start the services, we don't need to have it back. And so there's no problem here. We can just authorize the services for the eligible condition. The next situation is where a child has full scope managed care, full scope Medi-Cal with managed care. And if they have, if they do not have CCS, they do not have a CCS eligible condition, then those requests, say for an appendectomy or colds, flus, pneumonia, things that are not CCS eligible, the managed care plan takes care of those. In our county, it's Alameda Alliance for Health and Blue Cross. And Blue Cross is throughout the state. And so those requests come directly through the plans, and I didn't finish the line because we don't handle those. These particular situations are when there is no CCS condition. For our county, managed care services are here, and the CCS conditions and the services are carved out. We are a carve-out county. Some counties may be carve-in, where if a child has a CCS condition, it all has to go through the plans. With us here in Alameda County, as with many counties, we are carved out. So that means that they have full scope Medi-Cal with managed care. They also have a diagnosed CCS condition. The county, managed care plan may or may not know at the time that this child has been referred to CCS, but it doesn't matter for us because we're carved out. We know that they're full scope Medi-Cal. They have a CCS eligible condition, and we can authorize without doing a financial interview. These are full scope, and they're handled just like the straight Medi-Cal. Now, when we get into share of cost and limited Medi-Cal, share of cost, they may not be eligible for straight full scope Medi-Cal, so they have to put in a portion. A lot of these clients are eligible for CCS, but they do need to come in for a financial interview to take care of that share of cost. They do need an application and a program services agreement, as well as those that have emergency-only Medi-Cal. And the last category of Medi-Cal is gateway. These are kids that have, whoops, my mouse just ran away. These are kids that have temporary insurance, and it's usually the month that they are seen in a clinic, for example, Well Child Clinic. And it follows along the periodicity of the CHDP exams, the Child Health Disability Program exams. And so the younger the child is, the more frequent they are seen at these exams. And so they might be eligible for this exam and for this type of Medi-Cal for 2 months. It's the month that they were seen plus the next. So it's not, sometimes it's not always full 2 months. They do not need a financial interview. However, they need to come in, they need to, we need to review it in CCS so that they continue their eligibility, because if a child has a CCS eligible condition, and you know many of them do not end after a month and a half or 2, they need to have some permanent financial process established. And oftentimes before that temporary period of the gateway expires, we have our social workers follow up with the families to make sure that they have either CCS, CCS only established and made eligible financially, or that they get on full scope Medi-Cal. When a child has private insurance and Medi-Cal, the private insurance is primary. I think I mentioned that earlier. They are billed first, and for the PPOs and EPOs and all those, we can, we have them come in. They do a financial eligibility verification. They are now with the program, and on our authorizations, when we authorize the specialty care, we do a statement in the authorization that says that the primary insurance is billed first. When a child has Medi-Cal and healthy families, Medi-Cal is primary. Oftentimes a child may have a very serious condition, is eligible for Medi-Cal, and then the family will put the whole family, all the kids, on healthy families. So occasionally you might see a child that has both. In that case, our county has deemed that Medi-Cal is the primary. If the child has managed care, they will have IPAs attached to the plan. And these are individual physicians associations. They're assigned to the managed care plan, and they oversee the doctor's visits and the doctor's medical services of the physicians that are provided by this IPA, the authorizations, claims, and that sort of thing. For us, Alameda Alliance for Health, which is a managed care plan, has Community Health Center Network or Children's First Medical Group, and Blue Cross may have also those in our county. For Healthy Families, this Healthy Families is a state-sponsored program. It is a health insurance, and the family pays a premium to the plan to insure children through the age of 18. It's a wonderful plan, but they do need to keep up the premiums every month in order to make sure that all the children are covered, especially the CCS child. All Healthy Families clients are considered financially eligible. So even though they may have an income of more than $40,000 and they have healthy families, the child is still eligible for a program. A CCS application is sent out to the family, and then we send out an income verification, but it's for coding purposes only to find out if, and it's just to code the authorization, because they might be over $40,000, they might be an income level of under. These forms are not required in order for us to provide the CCS services. So absence of either the application or the income verification should not delay their services. Just an idea to let you know some of the contracted plans for Healthy Families. They're different in throughout the counties. For us, we have Access, Alameda Alliance. I won't go through all of them, but you can see that Healthy Families has quite a few. And it is very confusing for families when they get a card and it shows the name of the plan instead of Healthy Families at the top. So that is, it can be hard for some families. And they also have the Individual Physicians Association. So just like Medi-Cal. Your county may be very different from ours. A little bit about the BIC, or the Benefits Identification Card. It is very confusing for a lot of families because it identifies a lot of things. It identifies recipients of a state-sponsored program, which could include kids that are CCS only, In other words, they have no Medi-Cal, no healthy families, no insurance, nothing. It also identifies clients that have services of the MTP, the medical therapy programs only. And this could be somebody with an HMO, a commercial plan, whose only need for CCS would be the MTP. And so these big cards identify these types of kids. They identify any other state program. They can be misinterpreted as having Medi-Cal. It could also mean that the child has CCS or Healthy Families program. And the problem is that the name of the plan may show in big letters, but the name of the insurance, which is actually Healthy Families, is showing in very small letters. So, and a lot of plans look like private plans. They sound like private plans. They smell like private plans, but they're not. So this is something that the family really has to know, and in order for them to end up in the right place, they really need to know that, for example, Healthy Families is their insurance, but Blue Shield or Health Net or others may be the plan under Healthy Families. So some families may ask, and we do get these questions, why do I need CCS? I already have Medi-Cal. Well, the reason is that, you know, the state does mandate for CCS to case manage for Medi-Cal. Conditions are very complex, and so we do have nurse case managers who review the records. They work to get this particular child into the most appropriate, most cost-effective, most beneficial specialty care that is available. And CCS ensures access to quality specialty care. And so oftentimes CCS is behind the scenes authorizing and coordinating this care. Oftentimes the nurse will be reviewing reports to find out which is the most appropriate and to make sure that the child's case is opened in a timely manner. So there is a lot of behind-the-scenes activity within CCS, and we do use the Medi-Cal funding for those conditions. If there is for example, a piece of equipment that is very expensive, CCS will authorize it if it is deemed appropriate for the CCS condition, and the billing or the claim will go up to the Medi-Cal rate and not beyond. We do not pay for the difference between the Medi-Cal rate and what the vendor is charging. Why do I need Medi-Cal if I have CCS? Well, as I mentioned before, CCS uses Medi-Cal and Healthy Families funding. So Medi-Cal covers, additionally, Medi-Cal covers conditions that are not CCS eligible. So if a child has 2 or 3 different conditions, perhaps one of them may fall under that behavioral situation that is not CCS eligible. Medi-Cal will cover those services. For the non-CCS condition, primary care providers and vendors are paid directly by Medi-Cal. And so if they have Medi-Cal and they have a CCS condition, CCS needs to be involved. That's it for us. Are there any other questions?
Great, thank you guys. So go ahead and type in a question or raise your hand if you have some questions. I think Joan had a question from earlier. Let me see if I can unmute you. Joan, are you there?
Yeah, actually, my question is kind of related to the question that I forgot her name, the other lady was asking about. Her question was that her son was taken out of the program. My question actually is on the frequency of the services. My son was receiving like weekly services before, but then recently the therapist said, yeah, because he's not making that much progress, and the frequency is changed to like twice a month. So I just want to know, is this kind of like a normal thing is this a normal thing that should happen? I guess I have similar feeling as the other parent that, when your child is not making progress, that he's like taking away the opportunity to make more progress. So it's kind of like, it's kind of confusing. Just want to know whether is this something that happens a lot.
Well, the child's need for services will vary throughout his time with CCS. So it's not unusual for the physician to prescribe a higher frequency of therapy, and then less frequent when the opportunity to achieve gains is not there, or that the child just needs practice. And actually, that's one of the main reasons of slowing down on the therapy for a while. It's just that the child really needs to go home and practice some of the skills that he's learned, and the therapist should be continuing to monitor. And if the child seems ready to learn a new skill, that'd be the time to increase frequency again. But it's not the course with CCS is not to maintain the same frequency throughout the 21 years, but it will vary throughout the throughout the time that they're at the medical therapy program. When you go back to the MTC for the monitoring visit and for an assessment by the MTC physician, have your questions ready, have your concerns, have a set of goals that you'd really like to be working on with your child, and that's the opportunity to collaborate and to set up a new treatment plan. But don't feel that the what's being prescribed at one session is going to be the recommended for the rest of the child's life, but it will vary, and it will depend on the child's interest, what the goals are, and the child's ability to participate. Does that help?
Great, thank you. Some questions have come in. One of them is, how do you find out what type of Medi-Cal you have?
Well, we have, here at CCS, we have social, and that's something that we're learning all the time. There are systems here in Alameda County. We have something called the MED system, Medical Eligibility Data System, I think it is. And so if we have, and we have codes and we can look them up, and actually the website may be able to direct you to how to read these, but the CCS office can help you. For the most part, for the parents, their Medi-Cal worker would also be able to help them with this. We have to identify that when the referral first comes in. Otherwise, we don't know what we're working with. So if we find out that they have full scope Medi-Cal, the referral moves in as long as the child is medically eligible. But if they have a limited Medi-Cal or if they have share of cost, we need to identify that. And those are in the system that we have. Every county has some way of looking it up.
Okay, great. It's a question from Susie. She asks, can I clarify, if a patient is seen at a CCS Medi-Cal clinic for 1 or 2 visits under straight Medi-Cal and is found to have a CCS eligible condition, do we have to request CCS if we will not be seeing the patient again?
First of all, the physician that saw the child is probably a pediatrician, and we would not authorize them anyway. But if it's an ongoing condition like diabetes, then that pediatrician or primary care provider or that clinic needs to send a referral to CCS and have that patient have them at the same time with a condition like that seen at a tertiary facility if possible. But they do need to be referred, and we wouldn't authorize the physician necessarily that saw them because most likely it's a community provider.
Okay, great.
And if
yeah.
the child is not going to be seen again, then it's a moot point.
Okay. Janelle asked, this question's related to CCS coverage of audiology evaluations. Are 2 failed screens required, or may CCS cover hearing evaluation with other indications like physician concern, prescription, or documented concern regarding speech delay?
They should have 2 failed screening reports. We also have the newborn hearing program, and so yeah, they should. If for some reason the child only had 1 and they were sent to a tertiary facility, then with their Medi-Cal, and they do an evaluation, then we will take those reports. So, but yeah, the general guideline is 2 failed screenings, and I think they're about 6 weeks apart.
Great. So I think,
and also
yes.
that goes for a lot of other conditions. For example, I know we're running out of time, but we need to make sure that those reports come in, and the reports of the eyes and ears. So we do need some documentation, not just this is the diagnosis, but some justification of how they got to that diagnosis.
Great. Thank you, guys. I think we have come to the end. So if people still have questions, don't hesitate to email. I'll get them to our presenters today. We'll help you get your questions answered. I want to thank Sue and Terry so much for coming, talking us through this complex system, but it made a lot of sense, so thank you so much for helping clarify.
You're welcome.
Okay. Yeah, thank you.
And as a follow-up to today's call, everybody will receive a survey by email, so please take the time to complete the survey. And if you want to know about upcoming webinars or resources, please visit our website at familyvoicesofca.org. Next month's webinar will be more on insurance in healthcare. On Wednesday, December 3rd at noon, we'll have the Autism and Health Insurance, Making Your Benefits Work for Your Child, with Karen Fessel and Feda Al-Maliti, I think. Thank you so much for joining us today. You'll get an email with the link for the PowerPoint and for the presentation so that you can watch it later or forward it to anybody else. Thanks again, Terry and Sue.
You're welcome.
All right. Bye.
Bye.